Sometimes in our daily routine of taking care of patients, it's more looking at the treatment side effects. But the oncologic emergencies are very critical, both the metabolic and the structural oncologic emergencies, and something that we should, as a nurse, oncology nurse, just be very in tune and follow closely and be looking at those wide array of symptoms that can present with an oncologic emergency. They will kind of sneak up on you, and as an oncology nurse, we all need to be educated about them.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we're talking with ONS member Diane Cope, Director of Nursing and an oncology nurse practitioner at Florida Cancer Specialist and Research Institute in Fort Myers, Florida, about the latest nursing management and prevention strategies for syndrome of inappropriate antidiuretic hormone, which we'll call SIADH from now on. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Diane.
Thank you for having me. I'm excited to talk about SIADH. It's a very critical oncologic emergency that we all need to be aware of in the oncology population.
Well, then let's just get to it. How about if you give us some background on what SIADH is?
So SIADH is an inappropriate release of the antidiuretic hormone, ADH, and in its activated form is arginine vasopressin, or AVP. It is inappropriately triggered despite a normal or increased fluid balance. SIADH is all centered around fluid volume. So ADH completes synthesis in the hypothalamus and is stored and released from the posterior pituitary gland. When ADH is released, it is an activated form of AVP when stimulated. The AVP causes the renal tubules to absorb more sodium and water. So there's just basically an increased fluid volume. ADH is also secreted even though the osmolality is normal, causing a dilutional hyponatremia. So sodium begins to drop, which is some of the main issues in ADH. There's also a loss of potassium. The SIADH then stimulates a thirst mechanism, which adds to the imbalance of intake and output. Many different factors can cause ADH. It is often seen in some cancers, majority of small cell, but it can also be seen in non-small cell. It can also be seen in some solid tumors and hematologic cancers. There's also disorders that can cause SIADH. Those are neurologic type system disorders such as head trauma, infection, Guillain-Barré syndrome, meningitis, multiple sclerosis, and epilepsy. Some of our respiratory disorders can also cause SIADH. Pulmonary diseases consisting of chronic obstructive pulmonary disease, or COPD, in respiratory failure, asthma, cystic fibrosis, sarcoidosis, pneumonia, and also TB or TB. It can also be seen with those with a history of HIV. Also, it can also be seen with certain drugs. If someone has taken excessive antidepressants or NSAIDs, and also chemotherapy medications, including platinum compounds of cisplatin and carboplatin, the vinca alkaloids, vincristine and vinblastin, and alkylating agents cyclophosphamide and a phosphamide.
Thank you for giving us the background on SIADH. Now, can we talk a little bit about what the clinical manifestations a patient might exhibit if they were presenting with SIADH and what that might be so that a nurse could recognize that?
Some of the clinical manifestations that one would see are related to the neurologic and GI systems. For GI systems, they can include nausea, vomiting, abdominal cramps, diarrhea, and loss of appetite. Neurologic symptoms are most likely something that a nurse may note first, and it's really a change in mental status. There's confusion, lethargy. A family or caregiver may call in and say this person is sleeping more than usual. There may be headaches, personality changes, and just personality irritation or just being grumpy. This is something that should be brought to the attention of the providers and also something that nurses can really pick up on. Things that may trigger also is checking the lab values. Because of this fluid shift, which is going from the intracellular fluid is decreased. So that's pulling fluid from the extracellular compartments. You will see, if you look at the lab values, a decreased BUN and creatinine, decreased uric acid, decreased albumin. The urine osmolality and serum osmolality are something also that are followed. And you'll find a urine osmolality that is greater than the serum osmolality. So there's a lot of sodium being excreted. You'll see the biggest factor in a decreased serum sodium. And there's also a decreased serum osmolality. So the serum sodium is something that can be followed very closely. And that correlates well with what you're seeing actually in symptoms. It's when the sodium gets to 120 or less is where there's a very critical state. This can pull fluid into the areas of the brain and cause cerebral edema, which is a very life-threatening situation. So that's where you can see the confusion, lethargy beginning, decreased mental status, and it can actually progress to seizures and coma. So those are high alert things that nurses should be following closely and really noting any specific change.
So, with all of those manifestations that you just talked about, does SIADH have a similar presentation to any other complications where a nurse might have to really kind of do a deeper dive into figuring out or being concerned that it might be SIADH that a patient is experiencing?
As all oncology nurses know, the GI system being affected with many of our agents, just the cancer progression with certain cancers, you'll get the same type of symptoms of nausea and vomiting. Diarrhea is very frequent with cancer diagnosis and also with many of our chemotherapy agents, and also loss of weight. As far as neurologic symptoms, just the lethargy is very common in our oncologic patients. So that would really necessitate a nurse to look further. And the lab values are something that can definitely separate between a usual syndrome of the cancer and treatment, separating it to SIADH with the low sodium, the decreased BUN and creatinine, and then looking further as the urine and serum osmolality ratio.
That's really good to know, because I think you're right when you talk about, so many of our patients complain of that fatigue and just not having energy and lethargy. Looking a little bit further and being aware that checking those lab values would help differentiate that is so important. So, what are the risk factors that patients may have for developing SIADH?
The risk factors are multifactorial. They can be associated with certain cancers. The biggest cancer that we see with SIADH is a lung cancer. Most frequently, it's small cell lung cancer, but it can also present with non-small cell lung cancer. There are specific solid and hematologic cancers that can also be associated with SIADH, such as central nervous system malignancies, head and neck cancers, GU cancers, and ovarian cancer. Our cancer chemotherapy drugs can also cause SIADH. The specific agents that includes are the platinum compounds, cisplatin and carboplatin, vinca alkaloids, vincristine and vinblastin, and alkylating agents, cyclophosphamide and ifosfamide. In addition, some medications that are quite common to our oncologic population are antidepressants and nonsteroidals.
You've given us a lot of information about the different diagnoses that this syndrome can present with and what those manifestations would be. We have a lot of direct care nurses that listen to the podcast. So as they're listening to this and they're thinking about how the patients that they are taking care of, what should an oncology nurse teach patients and caregivers about recognizing SIADH? Because they may not be in the hospital and it might be not be something that you're recognizing with those inpatients, but more so patients calling in or family members that are going to be taking care of these patients at home.
From a clinical setting, the change in mental status is something that should be key information relayed to basically caregivers. Patients may not note that they have some mild confusion, but that is something that caregivers should be alert and call in and notify the provider. Really increased fatigue. I know sometimes we kind of pass that off as, that's the cancer, that's the treatment, but it's really that key listening to the caregiver and them noting that dramatic difference can really pull in education factors and materials that you can provide to the caregiver to note when they are home with the patient and something to report.
Okay, that's good. I think that that'll be super helpful for our listeners. So you mentioned the lab work that would be done to recognize this and to differentiate it from, like we were talking about, just patients who are experiencing kind of that normal treatment fatigue and lethargy. Are there any other tests that would be used to confirm SIADH diagnosis?
The biggest factor is patients usually get a chemistry panel as they're getting their treatment at some frequency. And that sodium is your high alert. If they do present with any sort of symptoms, that would be something that's easily seen. This always then prompts the physician APP to then order additional tests, which then would be urine osmolality, looking at specific gravity and also urine sodium. But really, your basic chemistry panel or basic metabolic panel will give you a first indication that something is not right, in addition to those presenting symptoms.
Okay, good. So now let's talk a little bit about interventions and support for patients who now have a diagnosis. You've looked at the lab work and can recognize, and they definitely have a diagnosis of SIADH. What are some of those interventions, and what would the oncology nurse's role be in those management strategies?
Looking at first the medical interventions that one would expect would be fluid restriction. This is usually about 1,000 ml or less per day. The patient is also instructed to increase salt intake, and then they may actually be put on loop diuretics to increase that free water excretion. So for the nurse, that would be trying to educate the patient on fluid restrictions. And this is always something very hard for patients because part of the problem with SIADH is that increased thirst because the fluid volumes shift. So really trying to work with the patient and caregiver and instructing the importance of that fluid restriction. Making sure that they can increase salt intake, providing a diet with items that will have a high salt content. And then if they are indeed prescribed a loop diuretic, information about how to take that and when to take that. Nurses can also be following the patient closely as far as monitoring sodium levels and hopefully seeing an increase in that sodium level back up to normal. And then also giving the caregiver instructions about following those symptoms. Because it's very frightening also to the caregiver to see the sudden change in the mental status and reassuring them that with the improvement of the sodium level, that should correct itself. Patients should also be weighed daily, and that would be information you could give and educate the patient and caregiver about keeping a weight diary on a daily basis. That is for monitoring increased fluid retention by the weight. If they are in the clinic, it would be very appropriate and required to auscultate lung sounds to see if there's any noted fluid edema in the lungs. And then maintaining a good I&O record. This can, sometimes we always think that that's in the hospital base, but that can definitely be in the outpatient. And again, along with that weight diary, instruct the caregiver on how to do intake and output and give them equipment so they can measure the output at home.
Now, Diane, let's talk about, we have a patient that had the manifestations. We did the testing, confirmed that they have SIADH, and interventions are getting started. What are some of the potential complications that are associated with SIADH?
The greatest complication that is life-threatening is the cerebral edema. At this point, the sodium would be extremely low, usually lower 120 value or less. And this patient most likely is being seen in the hospital setting. That can prompt severe side effects or severe symptoms of seizures and then coma. At this point, there's additional medical intervention, such as infusing hypertonic saline infusions so that you can work towards correction of that sodium. You don't want to, however, correct the sodium quickly because that could cause demyelinating syndrome in the brain. There's other agents also that are used. Demeclocycline is a drug that has been longstanding used. And then some of our relatively newer agents are vasopressin receptor antagonists. And these are for the severe hyponatremia setting. Also, with being in the hospital, you're doing seizure precautions, but that can also be a factor that you want to educate those patients and caregivers that are in the outpatient setting. So the seizure precautions and really further fatigue and lethargy is something that needs to be monitored closely, whether they're in the hospital or outpatient setting.
Such important things for our listeners to learn. As you mentioned at the very beginning, this can be a very serious emergency that a patient might be dealing with and that the nurse has to be aware of. So are there any age-specific care considerations for a patient that might present with SIADH?
Generally, you would watch for those in the elderly group as far as falls, if they become more fatigued, the lethargy. But basically, that can be in any age group. So there's really nothing more specific for an age. It's just really following their symptoms and following those laboratory studies. The symptoms can be basically presented in any age group.
Well, Diane, this has been very informative. Can't thank you enough for your expertise and the information that you've shared with us today. As we're at the end of our podcast, I just want to ask a few questions that we finish every podcast with each episode. And the first one is, what is something about SIADH that's not often discussed, but you wish people knew more about?
Sometimes in our daily routine of taking care of patients, it's more looking at the treatment side effects. But the oncologic emergencies are very critical, both the metabolic and the structural oncologic emergencies, and something that we should, as a nurse, oncology nurse, just be very in tune and follow closely and be looking at those wide array of symptoms that can present with an oncologic emergency. They will kind of sneak up on you, and as an oncology nurse, we all need to be educated about them.
What additional training or education do oncology nurses need to manage patients with SIADH?
Our basic oncology education is important. Sometimes we are focusing on the drugs because that's what is the main presentation of what an oncology nurse is doing, is administering chemotherapy and immunotherapy. But to go that extra content and also be looking at the oncologic emergencies as part of that training and education for any new nurse in the oncology setting.
What are some additional resources for both patients and providers who want to learn more about SIADH?
There's definitely a great deal of information through the ONS on SIADH. Marcel Kaplan has done many great textbooks on oncologic emergencies and really goes into depth with each one of the oncologic emergencies. For patients, it's just developing those teaching materials to provide them information but not scare them. However, things that they can be looking for at home and to bring to the attention of the provider.
Diane, again, I want to thank you for joining me today and for this important information. I just love this series on onc-emergencies because I think it's something that is so important. And we have so many new nurses that listen to the podcast, and it's just such a great tool for them and also a great reminder for all oncology nurses, what these emergencies are and how important it is to understand them and to know just the things to look for and how we manage them. So thank you for your information today.
Thank you for allowing me to speak on this. I think it is quite critical. And thank you for ONS providing these podcasts for our new nurses. Very important to really educate and get them well prepared in caring for the patients with cancer.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.